This is Gus Cairns here, the coordinator of PrEP in Europe. I'm just going to check that you can hear me. Hold on one second. Okay. Yes, we can, says somebody. Okay, all right. Thank you very much. Gus Cairns, coordinator of PrEP in Europe. I'm going to keep this very short because our presenters have some great stuff to say. Thank you very much for joining our webinar on PrEP for the trans and non-binary community. It's great to see you all. We've already got 43 participants. PrEP in Europe, as you may know, is a fairly loose partnership of European NGOs whose aim is to increase the availability and provision of PrEP to all people who need it within the WHO Europe region. So there we have quite a lot of people I see joining from Eastern Europe, which is great. There is interpretation available. If you go down to the bottom of the screen, you should be able to see a little globe with interpretation. If you are Russian speaking, click on Russian and you will hear the interpreters through your headphones. I think that's right. For English speakers, be aware that, thank you, Max, be aware that some people may be asking questions in Russian, which will get translated. So we recommend you listen to this on headphones. I'm only not doing so because mine don't seem to be working. So it's good to click on the interpretation thing and put yourself on the English channel as well. So thank you very much. This webinar will go towards preparing a large research briefing on the needs of PrEP in the trans community, which is largely completed, but will be completed with inputs from this meeting. And an innovation is that we had a community meeting for trans people in Europe before the webinar, and the inputs from that meeting will be presented by Dinah in the third presentation, and we hope to make that into a document of recommendations for the trans community's access to PrEP in Europe. Is there any other comments from the panelists? Oh yes, Max, who you should be able to see, is the sort of technical host and will be fielding your questions. If you have questions, please put them into the chat box. You should be able to see that and not the Q&A, because Q&A only panelists can see the questions, but in the chat box, as long as you make sure you ask your question of all attendees and panelists, and it will give you a little box to do that, then everybody will be able to see them. There are 3 presentations of about 15-20 minutes each, and we hope to allow half an hour at the end for panel discussion. Okay, I've kept that to 3 minutes. Anything I've missed out, panelists? Doesn't sound like it. So I would like to present Sari Reisner, who is a veteran makes him sound old, but he's not old, as you can see. A long-standing researcher into the needs of the trans community, based in Boston. And I'm going to let Sari basically introduce himself and basically present. Okay, Sari, if you wouldn't mind sharing the screen, go ahead with your presentation.
Can I just quickly jump in and just let people know, thanks Matthew for pointing that out, that we're recording this session, and just for everyone to be aware of that.
Oh yes, that's very important. It will be available probably after the new year because of Christmas on the PrEP in Europe website, and on and which will link to a YouTube version of it. The previous webinar is already up there. Sorry.
Great. Hi, everybody. Can you hear me okay?
Yes.
Okay, brilliant. It's wonderful to be here with you all. Always a pleasure to be talking about PrEP and trans communities and how we can make a difference in people's lives. So I'm based in Boston. I'm based in the USA. Don't hold it against me. And I'm just excited to tell you about some of the work that I've done, and also just to situate this this presentation, really to situate this webinar a bit for us. So, firstly, I think that we're in the project right now of really celebrating gender diversity. And I think this is really such an important and key framing for this conversation. And thinking about definitions and terminology, it's so difficult to come up with kind of terminology that fits everybody. In general, when we talk about trans and gender diverse people, we're talking about people with a gender identity or expression that differs from sex assigned at birth. And within that, there's a great amount of heterogeneity and a great amount of diversity. So trans people, transgender women, transgender men, non-binary people. One thing is the sort of cultural specificity of gender identities, and as we know, the need to really go locally and understand local terminology. So really, the point is that terminology is always changing; it's always evolving. And so the importance of really having the pulse on of what the local community is. One of the things we often get asked is, how many transgender people are there? Well, there's approximately 25 million. It really depends. In the epi world, any phenomenon depends on how you define it. So in the case of defining the transgender population, if we were to talk about people who have just presented at gender clinics and accessed medical gender affirmation, that proportion is actually much lower if we look at the prevalence of the population than if we ask people to identify their transgender status or being non-binary or gender diverse status. So that's another consideration, is definition of populations. And when we talk about cisgender individuals, we're talking about people who are not transgender or not gender diverse in some way.
Sari, can we just make sure to just keep the pace a little bit lower for interpretation to catch up?
Yes.
To be mindful of that.
Thank you, I appreciate that.
That we keep the Russian speakers also in the loop.
Yes, apologies. I know that I do speak quickly, so I will slow down. A good practice is often to use a two-step method in terms of data collection, in terms of collecting data on population and other surveys. So for example, asking about sex assigned at birth, and also asking about current gender identity. There's no single set of questions that have been agreed upon. So you'll see there are different response options that people give. For example, for the gender identity categories, people sometimes prefer not to answer as an option, but the sort of conceptual piece of assessing multiple dimensions of sex and gender is really the key in terms of transgender epidemiology in health, but specifically in HIV. So gender affirmation is really one of the core components. And I think when we look at transgender people's health, we can't look at health and well-being, we can't look at HIV without understanding this construct. And this framing is really a non-pathological one, right? It's a non-pathologizing way. It's really a departure from where we were, say, even 5 years ago. In thinking about gender affirmation being recognized or affirmed in one's gender identity as having multiple components. So thinking about the social aspects, name, pronoun, social interactions, and how gender is done between each other in gender roles in interaction with other people. Thinking about the psychological aspects. So this can include things like internalization of transphobia and stigma in the other world. Medical aspects. So this is where we're talking about hormones. We're talking about surgeries or other body modifications. In the case of young people, pubertal blockers to delay puberty. And then legal, around legal issues concerning name change, gender marker, and concerning the larger structures, for example, when there's criminalization. Or when there's discriminatory practices. So these dimensions are all worth considering. There's probably more dimensions. We're always continuing to push the field. So I encourage you to think about if there are other dimensions that would be helpful for your work and thinking about PrEP. But one thing is that, in terms of people's lives, it's not necessarily that as the individual, one goes through these series of steps in a linear fashion. So people sometimes may socially transition and never medically affirm, or vice versa. So there's no one way to move through this process. And also when we're thinking about legal issues in many contexts, for example, changing one's legal gender marker is still not possible. So the structural level barriers to being able to do that are very important for us to consider. So what do we know about the global HIV epidemiology? This is a pretty famous, at this point, meta-analysis that showed among trans women, about 1 in 5 living with HIV, overall a 49-fold increased odds relative to adults of reproductive age in each of these countries. More recently, if we look, for example, at data in the US, a more recent prevalence, we see laboratory confirmed about 14%, so it's a little bit lower, but still shockingly high. Incidence estimation, that is the number of new cases over a period of time, that we really are lacking data on, and that is something that is important, so we know how many new cases there are and how to slow that rate. In terms of HIV transmission risk behaviors, the meta-analysis found about 40%, engaging in condomless sex or some sort of transmission risk behavior. So this is for trans women. And I want to note that the active project of HIV epidemiology is really around categorization and the challenges of it, and for us to think critically about those challenges. So where are folks who are non-binary, who were assigned a male sex at birth or a female sex at birth in the epidemiology? And that's really one of the things that we need to improve, is learning more about populations that are not in the binary male-female framework. In terms of transgender men, really we do have limited data. The meta-analysis that I mentioned, which is a group of studies that were analyzed, you can see 3% or so in terms of laboratory confirmed. HIV incidence, new cases, I'm not aware of any incidence data right now in transgender men. Transmission risk behaviors, about 1 in 5. And then when we're thinking about transgender men and people of transmasculine experience, it's very important that we think about populations of gay, bisexual, queer, and other transgender MSM. And this really is a population, at potential risk at the intersection of double stigmas, multiple stigmas due to having both sexual and gender minority status. One thing to note is that we see a lot of heterogeneity in the trans population in terms of sexual orientation, particularly for transgender men. So in the European MSM Internet Survey, which Max was a part of, sexual attraction to women was way more common among those who were assigned a female sex at birth, who were trans men, 59%, versus those who were assigned a male sex at birth and were MSM, so cisgender MSM, trans MSM compared to cis MSM. So you can see a higher proportion kind of reporting more fluidity in attractions, all of whom had reported attractions to men as well. One other note in the epidemiology that we need to consider is the idea of intersectionality. So the multiple identities that people have and the status of how that can marginalize people. So if we look in the US, for example, this is the epidemiology and prevalence of cases. We see that Black and African-American people are bearing disproportionate burden among HIV for trans and gender diverse people. So the extent to which multiple forms of stigma are driving this is a very important consideration. So what do we really know about the drivers? We know that the drivers are multi-level. They occur at different levels of influence, and they occur together. They occur synergistically. So we can think about things at a biological level, things like receptive anal sex being higher probability of transmission per act probability. Think about STI co-infections, which can increase risk. At the individual level, mental health is a critical concern. Things like depression and substance use, post-traumatic stress disorder. These are conditions, and these are things that also are higher in trans people than in cisgender people. And so therefore, it's important to consider alongside the HIV epidemic. Interpersonal factors, gender non-affirmation is a major one. So not being affirmed in one's identity in whatever context that is, and particularly in sexual partnerships, and the need for affirmation and how that patterns risk. Violence victimization, including intimate partner violence, gender-based violence, network level factors. So we have higher HIV rates in the prevalence, higher HIV rates in partnership pools. So among the partners and the network. And we see, for example, that in sort of high risk sex work environments. So in a sex work context, having exposures that increase vulnerability. So for example, we have, there's some data on molecular transmission, which really is looking at the specific nodes in the transmission of particular aspects of HIV. And what we see here, this is a study in LA in USA among more than 2,000 unique individuals, of whom 2% were trans women. And what they found in looking at this analysis is that there was a clustering of trans women. There was a very high linkage of trans women with cis men not identifying as MSM. So, and a low linkage with cisgender MSM. So it's something that we've know, but it's also something that we're seeing actually in the molecular transmission of HIV. So this is an example of a network level factors that we can really seek to understand the prevalence of HIV. Of course, we also have community and structural factors, and these are critical. I mentioned some of them before, but really the processes of stigma and social exclusion and structural factors such as lack of legal protections, really driving on a population level the HIV epidemic. So this idea is that we must understand the context and the lived experiences of people's lives, how the vulnerabilities for HIV are situated in so many other factors, including, for example, in youth, bullying, poverty in adulthood and youth, harassment, etc. So, these are core issues that in order for us to address the epidemic and address PrEP uptake will need to be considered alongside interventions. So the most really important strategy is to work with communities and thinking about a participatory population perspective, having communities participate in the EPI, participate in the intervention design and delivery. And this is really a critical value and really positionality to come from in terms of PrEP delivery in order to meet population needs. So what do we know about PrEP and some of the data that we see? Well, I wanted to share some data from the LIGHT cohort, which is a cohort of transgender women that I've been working on with Dr. Andrea Wirtz at Johns Hopkins. We enrolled more than 1,000 transgender women in the Eastern and Southern United States, some in person, some particularly online. When we looked at the baseline assessment, overall 30% were living with HIV. So that's, and this is laboratory confirmed. But we did look at PrEP indication among the HIV negative sexually active participants in baseline. And what we see is about 41% were PrEP indicated based on some CDC criteria, including the categories below of condomless sex, sex work, STI, and having a sexual partner living with HIV. So when we look at the PrEP continuum in that group, what we see are 82% heard about PrEP, which is high levels of knowledge overall, but really low uptake. So 27% reporting lifetime PrEP use. And so that gap between hearing about PrEP, needing PrEP, and then PrEP use is an important one and one that we need to fill. And when we look at the correlates of PrEP use, we see that it was associated with sex work, substance use, and being age greater than 24 years old. So in some cases, where the people who may be at greatest vulnerability, including sex work and substance use and vulnerabilities in that nature, are maybe more likely to be getting PrEP in this group. But concerningly for me, that the age greater than 24 years are more likely to be having PrEP. So we are missing the young people. So there's a real gap and a need to go in the life course, earlier in the life course, and to really look and see what young people need and to meet those needs. And so the early intervention practices are going to be very important. If we look at people's experiences, trans women's experiences in the cohort, we see that some of the barriers and experiences were disliking daily pill, side effects, and perceived promiscuity. It's interesting in this sample that only 9% reported interaction with hormones. But that's also a self-report in terms of its experience with hormones. What do we know about transgender MSM? So I was fortunate to do a study with Dr. Ken Mayer, looking at the PrEP cascade. This was an online sample of more than 800 trans MSM. Overall, you can see that 1.6% were living with HIV. So among those who were negative, 84% had heard of PrEP, 67% had an interest in PrEP. Overall, looking at PrEP indications, more than half were PrEP indicated. And in this sample, the factors that were associated with PrEP indication were having a gay identity versus some other identity, either straight or queer or some other identity, psychological distress, alcohol and polysubstance use, having a higher perceived risk, and then having experienced cisgender partner stigma. And specifically, this was stigma around gender non-affirmation of identity. So having a partner question his sexual identity after having sex with trans MSM, having one's body referred to by incorrect names of particular body configurations, and general disrespect in a sexual encounter. And actually that was reported by 78% of the sample. So the need to really consider this trans-specific factors that are driving HIV risk cannot be understated. So we need to consider the general quote unquote risk factors that we might see in any population, but for trans folks and gender diverse folks, really be the specific exposures and vulnerabilities that unfortunately we may experience. So in summary, we see a high burden, as I think we all know, of HIV in trans and gender diverse people. It is a diverse population. It's a population that we need to celebrate and understand the diversity more, and also that has implications for PrEP delivery and HIV prevention activities, some of which are contextualizing these vulnerabilities. So for example, understanding intersectionality, thinking about the multiple identities that people hold and how that is important for the delivery, and particularly the focused prevention efforts and delivery methods. We see clearly in the literature that there's a gap between the indication for PrEP and uptake of PrEP. And I think that's why we're here. How do we fill those gaps? What are the strategies that are needed for us to lessen that gap? And then the need to really work with and not on communities to enable to do this. And this is such a key component. I've talked a lot about vulnerabilities, but there are so many factors that we need to understand which are related to strengths. And unless we leverage those strengths, we're not going to be able to make the huge impact that we would want to. And particularly, I would say the impact that we would want to in order to be able to empower the community. And that's going to be a key ingredient for us to empower folks to take PrEP and who would like to do so. And for us to really give people the choice, give people having active choice in their lives to be able to protect themselves or not use prevention strategy as they need. So the combination approaches clearly are the piece that is the direction that we need to go in. And because PrEP uptake will depend upon adherence, it will depend upon adhering to a regimen. And as we kind of move into other long-acting and other forms of PrEP, there will still be issues around access. There will still be issues around behavioral change, and there will still be contextual issues that we need to face at those multiple levels. So this is really sort of a 5-dimensional figure if we think about this, right? We think about it occurring at multiple levels. We think about it as having multiple components. We think about it as having multiple populations, and then we can contextualize all of this within the other health disparities that transgender people face. And so the root really around this is those structural inequities. And that was going to be key for us to increase PrEP in trans communities and meet the needs of transgender people. And that's basically in this meta-analysis that I worked on, what we need to do is it's difficult to successfully prevent and treat HIV infection in isolation from other social, behavioral, and medical conditions that co-occur. And these really interact to limit successful and sustained engagement and care. So the really question is, how can we flip that script? How can we flip that script? And it will be critical to do so with transgender people. So thank you very much.
Great, thanks very much, Sari. That's really comprehensive introduction. I have a great question from one of our participants, David, which says, now I think what we'll do with this question, because it relates specifically to the European context, is, if you don't mind, David, we'll ask you a question in the panel discussion at the end. It says, how can we relate data from the USA that have no healthcare system, they have a sort of customer health system, with European data that have a completely different mentality to healthcare approach? I think that's a great question, but I think it's probably one after we've heard about the European context in Dinah's presentation. I have a few opinions on that myself, having tackled with the English NHS when it was originally debating whether to allow PrEP at all. Okay, thank you very much. If there's no more questions, I should say to people who joined late, put your questions into the chat box, making sure that they're addressed to panelists and attendees, not the Q&A box, because that means only the panelists can see them. And we will, and Max or I will pick up on them and answer them either immediately after presentations or at the end. Okay, thanks very much. Okay, I would like to introduce Dr. Akarin Hiransuthikul, I hope I pronounced that right, who is from Chulalongkorn University in Bangkok. I wanted somebody who's from Thailand because I'm aware of the great work that they've been doing with their trans community there. And of course, culturally, Thailand is a country that has always been accepting of a non-binary genders and of a third gender. And they are doing great work there. And furthermore, I know that they're exporting some of the models and the approaches to other Southeast Asian countries, like, for instance, there's some great work being done in Vietnam. He will talk both about the data specifically on hormone interactions and things like that, that I know worry a lot of trans people, though it was interesting to hear from Sari that has become perhaps less of a concern, but also with the campaigning they're doing over there. Akarin, do you want to share your screen, or is Max going to do it?
Yeah, sure. No, I will share my screen.
Okay, great.
I think you need to give me the permission first. Gus, can you allow me to share the screen?
Yep. Oh, sorry, I have to do that. Right, sorry about that. There we are.
Yep.
Right, okay.
Okay, great, thanks. By the way, perfect pronunciation of my last name, Gus.
Sorry?
Perfect pronunciation of my last name.
All right, well.
Very difficult. Okay.
I worked in Thailand for a short while.
Well, thank you, Gus and PrEP in Europe team. Oh, yeah. Thank you, everyone, particularly Gus and PrEP in Europe, and thank you for the kind introduction for the work in our country as well. My name is Akarin. I'm not going to bother with the last name. I have been working extensively in the preventative field, especially. Yeah.
You're also talking quite fast, so slow it down.
Okay. Sure. Thanks. I have been working in the preventive field, particularly with the trans population and in general STI for the past 4 to 5 years. But I also have strong interest in neurology. So that's why right now I'm my last year of my neurology residency. So a little bit conflicting. And I'm still considering myself as a junior healthcare personnel. Okay, so overall, what I'm going to be talking to you today will be quite a focused topic, and that is drug-drug interaction between gender affirmative hormone therapy and PrEP among trans population. And of course, I will be put my main focus on the IFAC study, which is the study that we conducted and already completed. After that, I will talk very briefly about only a handful of other related studies, and also what are futures in our team right now. And I'll close my presentation and talk about a campaign, very exciting campaign that we recently launched in Bangkok, called PrEP in the City. So one of the things that is unique to trans population, I would say particularly transgender women, because we have a lot of data as well, is that there are gender affirmative hormone. In this case, it's feminizing hormone therapy that this particular group of individuals use. And among one of the studies that really raised our interest in doing the IFAC study is this one, is the data from Dr. Deutsch and the team who they conduct a post hoc, some group analysis from the data from PrEP trial, and found some issues with PrEP and transgender women. So they found that transgender women were more likely to have undetectable drug levels, and particularly more proportion in those who use feminizing hormone therapy. And none of the transgender women who seroconverted had detectable levels of tenofovir. And we had two hypotheses to that findings. And we came down to the keyword of adherence. So firstly, transgender women may actually have good adherence, but there was some kind of drug interaction that between the two drugs, the hormones and PrEP, that decreased the level of PrEPs. Or secondly, and I would say more simpler, is that transgender women have poor adherence to PrEP. Anyhow, if that's the case, there are many surveys suggesting that this could be due to majority of transgender women prioritize the use of hormone therapy over PrEP. So I would say either way, whether they have good adherence or poor adherence, drug-drug interaction still plays a role. And that is why we conduct the IFAC study, or the study to determine interaction between the use of feminizing hormone therapy and antiretroviral agents concomitantly among transgender women. And you can see that I use the term antiretroviral agents rather than PrEP. And that is because our study have, I would say, I'm not sure about the word I use it, but maybe we call it two sub-study. One is those among PrEP, and the other one is among using ART. So for PrEP, the one that we're going to talk about today is HIV negative transgender women who will be using PrEP. And for the other on the ART arm is the 20 HIV positive transgender who will be using ARV as ART. And as I mentioned before, our study are already completed in both arms. So the PrEP one published in JIAS, which I will be talking about today. The other one is CAD. I'm not going to talking about that today. So for the study drugs in our study, what I meant by PrEP is the daily TDF FTC. And what I meant by feminizing hormone therapy is estradiol valerate plus cyproterone acetate. So we control the doses of the feminizing hormone therapy. And this is very important to emphasize that the regimens, the hormone regimen used, not only differs between each country, but also within the country, between each region as well. So it's very challenging to do this kind of study. But again, when we come back to the objective hypothesis, we really want to determine the drug-drug interaction. So we want to control all the environment, so we make sure that not a confounding factor in our results. And I will be spending much of my talk here on this slide, very important to understand the study design. This will also lead to the understanding of our future plan as well, because we use this as a template. I think I will start with the first part is what did we measure? So you can see, I'm not sure if my mouse is in here, my pointer. So you can see at the triangle, the red triangle shows a measurement of the hormones. So we check for hormones, we check intensive PK for E2 estradiol, and concentrate at 24 hours of testosterone. This will be done at week 3 and week 5. The other measurement, the brown triangle, we check for PrEP level, but we only check for intensive PK of tenofovir. And the reason we did not check for emtricitabine is very simple. It's because that our lab is not available to And now for the most important part, I would like you to understand like the study visit. We have 5 study visits. It's entry, week 3, week 5, week 8, and week 15. So week 15 is for safety purposes in the context of PK that I will be talking. I'm going to leave that out, and we're just going to focus on these first 4 visits. So at entry, we will give the participant the hormones, the estradiol and cephalosporin. But the hormones require, and this is very important, the hormones require 3 weeks to reach its steady state. That's why after we initiate the hormone every week, in order for hormones to reach their steady state, then it will be the optimal time to check for this one, the hormone levels. So week 3, we will check for hormone level only. After we check the level, at that same visit, we're going to initiate PrEP. Now, PrEP is a little bit different from the hormones. PrEP requires approximately 2 weeks to reach its steady state. And that is why 2 weeks after that, at week 5, we have the participant come back and then check for the PrEP level, as in the tenofovir measurement. But the hormone level already reached their steady state since week 3. So week 5, they will be at the steady state as well. This is why we check hormone at week 5 along with the PrEP level. At week 5, after we did that, we're gonna temporarily discontinue the hormones. So right here is a blank. We discontinue that, and we need to wait for another 3 weeks so that the hormone that we stop is completely eliminated from the body. When the participant came back at week 8, the PrEP level that we check right here will be PrEP only without the effect of the hormone. So this is why our study is a 2-way drug. The effect from PrEP towards the hormones and also the hormones towards PrEP. And ultimately, what do we get? What do we get is that when we compare the week 3 and week 5, we get hormones level in the absence of PrEP versus in the presence of PrEP. And when we do a comparison between week 5 and week 8, we get in the presence of hormones and in the absence of hormones. So let's look at the results.
Akarin, you are breaking up a little bit. I don't know if you're near your modem or what's happening. I think it's at your end, not ours. So just sort of try and take account of that.
Oh, is it a lot, guys?
It's, I think, still okay to follow what you're saying, so it's fine. Like,
yeah, it's fine, but I mean, just be aware of that.
Thank you. Okay, thank you. So the first part of the results is the estradiol, and well, basically that you can see that there are no significant differences between week 3 and week 5, as in hormones level in the absence of PrEP and hormones level in the presence of PrEP. So there was no significant differences for hormones. What that means is that PrEP doesn't significantly affect hormones. What I did not show here is the testosterone level. We also found that there was no different change in the testosterone level as well. So that both are good news. Now the last portion of the results in the original IPREC study is the tenofovir level. Again, week 5 is the PrEP level in the presence of hormones, and week 8 PrEP level in, and we can see at the GMR, geometric mean ratio, and some other significant changes. So we see that there were significant reduction in the tenofovir exposure. So it would be 12%, and the concentration at 24 hours around 18%. So what this means is that pharmacologically, hormones significantly affect the level of PrEP. But pharmacologically only, we cannot conclude in the clinical aspect. The conclusion from our study is that there were no significant changes in the hormones level, both estradiol and testosterone in the presence of PrEP. So this suggests that transgender women can confidently use hormones without the concern that PrEP will diminish the feminizing effect. However, when we look at another part of the result, we found that the blood tenofovir exposure was significantly decreased by 12% in the presence of hormones. And I really need to emphasize again that this is pharmacological aspect only. We cannot conclude the clinical aspect of it. Another thing that I would say, and optimistically from our result, is that despite these significant changes pharmacologically, all the participants had detectable tenofovir level, regardless whether they were on hormones or they already discontinued hormone. So that's another good news as well. And I want to emphasize on the limitation of our study as well, and that other studies, well, some already have results, which I will talk in the next slide. Other studies to check whether this interaction occurs in target tissue as well. Remember, the study only checked the blood component. How about different hormones regimens? I mentioned earlier that there are so many variety of regimens there. And last but not least, the clinical significance of this 12% reduction in tenofovir. For other related studies, that to my knowledge, there are only like a handful of it, only 3 studies. I'm starting with the left one from Dr. Cottrell and her team at UNC. They found that transgender women who took feminizing hormone therapy had a 7-fold lower rectal tissue ratio of PrEP's active metabolite compared to the competing deoxynucleotides compared to cisgender women and men. And the right upper one is from Dr. Hendricks and their team from Johns Hopkins, found that the plasma tenofovir and emtricitabine as well were lowered by about 1/3 compared to cisgender men. So both these studies, the one from UNC and the one from Johns Hopkins, along with our IFAC study, showed similar results in that hormones significantly reduced the level of PrEP's component. But last but not least, the latest one, the right lower one, just recently published in CAD in August, Dr. Grant and his team showed that there was comparable tenofovir level in dry blood spot between transgender women and transgender men, and also in transgender women and cisgender men, and all were projected to reach the tenofovir diphosphate threshold for HIV prevention. So this study kind of like confirmed that, okay, yes, there are some effect from the hormones, but it is very small and it's not expected to affect clinical protection from PrEP. And finally, some of these studies also show similar results in the aspect of PrEP towards hormones, in that there was no significant effect from PrEP towards hormones. So I think this is a very nice finding to eliminate all the prioritization, all the concerns. And this is our future plan. Very soon future, we will launch 2 studies. The left one is IFAC3, the right side is IMAC. And these are the infographics, well, of course, in Thai to communicate with our participants. IFAC3 is similar to the IFAC, except that we will use TAF FTC instead of TDF FTC. And we will do a much more laboratory testing, PBMC, and hopefully rectal tissue as well. For IMAC, we are very excited about this one. I completely agree with what Sari mentioned earlier, that the data among transgender men is like super limited. And this will be our first study on drug-drug interaction to conduct among transgender men, where M instead of F, M stands for muscular therapy. We plan to enroll 40, 20 for TDF FTC and another 20 for TAF FTC. The concept is similarly to the original IFAC and to the IFAC3 as well.
Akarin, we've got about
okay, and I will close.
2 or 3 minutes, so if you just run through the campaigning side of things very quickly, thanks.
Okay, thank you. Yeah, I will just end with about updates on the campaign that we just recently launched in Bangkok. and it's called PrEP in the City. I got these beautiful slides from Rina Janamnoisu on the right hand side of the picture. She's head of the program and also the manager for transgender health in our institution. The goal of the campaign is to increase the uptake and accessibility of PrEP among transgender women. This is the first PrEP campaign for transgender women in Asia, designed and produced by transgender women. And one of the key points that our campaign wants to achieve is to provide gain-framed messages rather than risk reduction messages around PrEP use. And also, we would like to enhance the visibility of transgender women in Thai healthcare system as well. Well, hopefully we can give you some updates of how the campaign is doing, because it just recently launched in September in the near future. Yeah, and that will be it for my presentation. These are some of the key people. Special thank you to the transgender participants who led us to be able to provide this information for you. Thank you.
Okay, great. Thanks very much, Akarin. That's wonderful. Thanks for pursuing it through the slightly poor sound. I've got a couple of questions specifically for you. One says, did you look at the mental health aspects of taking participants off their hormones? Was there any sort of distress at actually taking part in the study because they'd have to come off for a short while?
Well, we did not collect the data for that, but we definitely informed prior to doing the study. But so yes, the answer is no, we did not collect the data during that. But we have a very close staff to participant communication, because these are intensive PK studies. They need to say like 24 hours, so get quite close to the staff, and we did not encounter that problem.
Okay. And also somebody is asking, is there an argument for also doing a reverse order version? So, you know, that you reverse the order in which you stop the medications to control for possible effects dependent on the order.
Sorry, I don't. Can you maybe repeat that again? I'm sorry, it's my English. I'm not understand that.
Yeah, as far as I remember from the trial schema, you took participants off their hormones for a while and then put them on so that you could measure the time on tenofovir without hormones. Could you do it in reverse, as it were, stopping the tenofovir?
Ah, so you mean like maybe
in case there's time differences in terms of
temporary discontinued PrEP?
Yep.
Oh, okay. So if I understand correctly, the question is basically, can we temporarily stop PrEP instead of hormone and do it kind of like a reverse method, something like that? Well, my answer would be I don't see the necessity to do that, because when we do this, we're using the pharmacokinetic information. We are confident that during that time, the hormones will, when we discontinue the hormone, it will be completely eliminated from the body. So whichever way it goes, you still have a very good data from hormones only, very good data when hormones and PrEP are using together, and very good data of PrEP only. To do a reverse algorithm, it will get it will get the same result, but we feel that we don't feel comfortable temporarily discontinue PrEP, because that could kind of feel like the risk compared to the hormones.
Yeah. Okay. Thank you very much. All right. I will ask the other questions after Dinah's presentation, as I said. Dinah, tell us about the community meeting you had, the interesting data that came out of it, and whatever the outcomes for that we can work on.
Yeah, thank you for having me and having the opportunity to speak on behalf of the community.
Sorry, I forgot to introduce you. Okay. You are also a long-standing trans and indeed health activist. I was very impressed that you've been a parliamentarian, and you are the coordinator of Trans United EU, which is a European-wide advocacy organisation for trans people.
That's the organization by trans people of color, and I am the chair.
Okay, thanks.
Should I start sharing my screen?
Yeah, Max, please. Thank you.
Yes.
So I did this together with Max. We also arranged together with other people as well who have been involved.
Yeah.
In the meeting. So the meeting was. Yeah, so that's me. Thank you. The meeting was, we reached out to all the people that we knew in respective organizations and countries, and we really wanted to have a good mapping of the whole of Europe, but unfortunately it was not possible to reach out to the southern countries such as Spain, Italy, Greece. We did not have them in the call, but the countries that were involved, you see them here. And they all participated with really good information from the community. And it was a real good moment as well to reach and to speak out things that are happening in the community when it comes to sexuality and sexual health care, together with other issues that we face. And I will come into that in the next slide. So country specifics, and we also did it in with the Russian translation. So we also had inclusion of the Russian speaking countries, which was very good. As you see that in certain countries, PrEP is not available. In Belarus, for example, in Kyrgyzstan, it is tested with the support of the Global Fund, and the sample is 100 people. So there are 100 people involved in that project. Trans people are not directly included. So that's already one of the things that we found out. It's problematic because they are then they're under the MSM contact, which is not actually something for the trans community. Then like that's something not working yet there. In Belgium, it's available, but one must fit criteria as a risk group, and it's also then only covered by health insurance, which is then reimbursed, which is also again, well, it's a threshold for trans people because many of us don't have a fantastic financial income. So that is already something that's really not helping. In Belgium, Denmark, only the key populations have access to PrEP trials. Trans men were broadly excluded, but that changed recently. So we also see here that even in the Nordic countries where we would love to, well, we always think it's very well arranged, and it's actually very harsh to see that the trans men in this, and also that should include non-binary people, are not included and face risks. In France, I spoke also for France. That was in the beginning maybe not clear because France was not in it. But I'm also living in Paris, and I know from there that it's fully available and it's covered by the health insurance. In Germany, it's available and as well covered by the health insurance for at-risk populations. Can I see the next slide? Thank you, Max. In the Netherlands, where I'm currently at, there is a pilot amongst MSM, but MSM is defined, let me go, to be inclusive of trans folks who do sex work. And that's already a problem because it doesn't match with the whole of the community. Not everybody does sex work or due to the stigma is able to access those healthcare lines. So it is accessible through the sex work municipality healthcare system or the project that's run. But one must identify as a sex worker. So in here, we as Trans United have been working together with with the municipality to have broader access. And it means that we as a trans community have our own clinic and we can host it in the municipality health network as per the 1st of January. And we also will give PrEP access to the whole trans community, meaning everyone in in our community. The north of Macedonia, PrEP is accessible only for health workers and not for everyone. This was also very strange. Well, health workers only. A new study is among 300 MSM and trans people. It's currently in progress. In Poland, PrEP is available, but mainly for the gay and MSM community. So it is not separately for the trans community. There are also other thresholds that include money issues and payments. Can I go to the next slide? Yeah. Tajikistan was, of course, done in Russian, and the PrEP is being tested in a pilot version, supported as well by the Global Funds. It's the same sort of structure, 100 people, and trans people are, again, not directly included, but again, put under the category of MSM. And in the Ukraine, PrEP is available for the LGBT community. Trans people in general do not know about PrEP, so there is no outreach towards the community that get people into the programs. And there is also disbelief, but we talked about that later, about the interaction between PrEP and hormones. Okay. Thanks, Max. So PrEP in Europe, the general issues and access to and barriers to the sexual health care. Very important issues brought up by the overall community from all over Europe: poverty and low legal education of the trans community. Trans employees do not reach the preventive programs, and they do not meet the needs. For trans sex workers who often experience client pressure and do not use condoms, PrEP might be an answer, but the community needs to be informed and encouraged to use this opportunity. One of the things that, we found out as well is that Spain and Portugal, for example, were very difficult to get into this meeting, because they said for us it's really not an issue, because in Spain there is not even a talk about PrEP, and it's not even there's nothing that helps us, and we don't know why we should be part of this conversation. So it's already, well, you see that that's also very governmental. The lack of provision of services and preventive care, and there is no trans competent medical help, pressure pathology by healthcare providers. Cis people are involved in outreach and service delivery, but not the trans community, which is really something that says something about let's say the best practices that we have in Europe around this kind of services that are to be found in Amsterdam and in London and Paris, where you see that the trans community is the leading part of, let's say, the anamnese and the first check-in. After that moment, there is a doctor seated in another room, and then the community services actually can work very well with the doctors, and it helps people to get into the lines of services. There is no specific services developed by the trans community itself. Can I see the last slide? I think this was high level of poverty and social victimization, harsh living conditions puts the issue of HIV prevention into the background. Xenophobia, which is also which we also saw from the US, where high level numbers of POC people are involved, and then with xenophobia, there is also in Europe an issue. HIV stigma experienced from cis people, too little information about prevention and treatment, access barriers for non-conforming, non-binary people and migrants are elevated in many countries. Refugees and people in the asylum system are left out as well, which is really a big issue, especially in Europe, where many refugees are coming in. The lack of legal gender recognition in some European countries. Global issue that we do not have enough information on drug-to-drug interaction. So that's actually what we've heard from a bit from Akarin. We didn't know anything about that, and specifically on HRT and ART PrEP. The power dynamic in sexual relationship in between trans and cis partners. That was also a very important topic that we discussed in our groups. And that is, I think, the end of our focus group meeting.
Yes. Thanks, Dinah, for sharing the points. Like, this is basically just as an explanation. Like this,
yes,
we
Max,
gathered these points. We gathered these points together with I think we were about like 25 community members from all these countries that were listed, and kind of just tried to figure out an overview of what is currently happening and what is needed. Where do we need to go next? And at this point, I would also like to say thank you for like Dinah. Helped organizing it, as well as Keenan from ILGA Europe, Leo from TGU, and Timo from Ukraine. Like, we tried to also, like, you know, have different, like a organizing committee with reach out to different parts of the community, and those are basically like what you just heard were just voices from the community and the needs and the problems pointed out.
Okay, thank you. That was fantastic. I mean, that's a real sort of, I mean, these lists of issues can come across as depressing, but I think it's a really good list of things that we need to sort of start or continue advocating on and working on. I think it sounds like a really productive meeting. I've got about 5 questions that people have been asking over the webinar, but they're all fantastic, really good questions, and so probably that might be enough for the time we have, the half an hour, exactly half an hour. Well done, everybody. Time that we have for the panel discussion, and I think the one I mentioned is probably key, especially as regards what we've just heard. What are the differences you see and how between the US and EU healthcare systems when it comes to the provision of PrEP? And is there something about the way that European health systems run, this is my addition, that contribute to that lack of access to PrEP for trans people? And please, any of you feel free to talk about this. And don't forget to unmute yourselves. Max, you can.
Yeah, I mean, I see that. I mean, it's a very good question, because there is certainly differences in healthcare systems, but the problem is, like, and we've heard this all along, like all the 3 presentations, is that it's like also on a social level that we don't have access to healthcare in general, because there's a lack of healthcare providers knowledgeable about the needs of our communities, what happens in our bodies with hormones, or maybe not hormones, like some trans people do take hormones, some trans people don't. But like usually if I go to see a doctor in general, which is, you know, like already a problem, like to find a doctor that I can just talk about my general healthcare needs, but then finding someone who I can actually talk to about my sexual healthcare needs, that is a completely different story. And that is something that is something that we see globally. And obviously, like, there's different aspects, different points that we need to take into consideration, that the general access to healthcare for trans people is very problematic all around the world, specifically when it comes to healthcare, because like we're not, like we saw it also in the presentation that Sari was given, that we're not even given the information about PrEP, because there's these stereotypical assumptions of how and with whom we're having sex, and that we may not need, like that I go to the doctor and he sees me as a masculine presenting person, thinks like, oh yeah, that guy is probably just like having sex with cisgender women, so I don't need to give him information about PrEP. But that I actually do have sex with cisgender men, like it doesn't even get to that point where I'm being asked that question, and that is a problem that I think that we can transfer from, like, or where we can transfer data about inaccessibility to healthcare from the US also to the European context.
Okay, brilliant. Sorry, I don't know, you were nodding away there, and also this question was originally asked of you.
Yeah, I mean, I think it's such an important question, and you know, the extent to which globally we can learn across countries, you know, and think about those lessons applied. I mean, I think what Max was saying was similar to what I was thinking, you know, around the fact that stigma is everywhere, and trans competent care, you know, when there is access to services, let's say, even if cost is covered, there's still those barriers. There's also issues around ongoing monitoring with PrEP. It's complicated, right? It's not just getting PrEP and that's it. There's routine visits, there's ongoing things, and the priorities of populations are probably not PrEP, right? I mean, given the contextual issues that people are facing, So that's one of the things. And I think one piece is there, there was a study or a project by Hayes in 2019, I can post the link, which also showed that like, despite differences in delivery, that cost is still an issue. It's an issue, and it will remain an issue, in terms of the economics of it. So, I think those are shared lessons. And I want to also note that Dinah talked about, the heterogeneity of availability of PrEP in Europe. It's not that it's the same across all of Europe. And so we really need to look at the country-specific lessons and be able to also apply those. It's a great question. Thank you. I'll post that article in the chat.
I'll add a tiny bit of myself, though, as host, that I don't want to wish to hog the space. That's, as it were, the sort of the bottom-up community experience of what it's like for trans people when they go to a healthcare worker and sort of meet with these assumptions. I think the other thing about Europe is that as mainly having countries with centralized healthcare systems, whereas in the US, there are sort of ways to get what you need if you are persistent and privileged enough. In Europe, it's all done through very centralized bureaucracies, even in the sort of rather creaking post-Soviet healthcare systems of Eastern Europe. And I know that the other aspect of this is that it was difficult enough to get PrEP for gay and bisexual men in many countries because they often have to go through a whole cost effectiveness and effectiveness decision-making process, which can take a very long time. And so you have to be able to prove to politicians and policymakers, some of whom may not be at all gay or trans sympathetic, that this is a necessity and would really improve the general health of the public they're supposed to serve. So that is also the sort of the top-down issue is very prevalent in Europe, and each country has its own system. So one of the things we face in PrEP in Europe is to try and draw lessons which one can apply to all those systems. Just while we're still on this topic, I've got one more supplementary question. Do you think that trans people, I mean, is cost a prohibitive factor in the USA specifically, and do trans people have more difficulty accessing PrEP assistance programs, do you think? Sorry.
Yeah, cost is certainly an issue. In the trans MSM study data that I showed you, cost was one of the primary barriers, but also a primary factor why trans MSM were not interested, because of the cost. I think in terms of the access of services, even assistance programs, it's challenging. There's paperwork to fill out, there's mailing, you need to, go to, mailboxes, and having a home address to have mail returned to for people who are unstably housed, so there's always barriers. And so the idea is like that the availability of the services, even when they are available, we have a gap between accessing services and availability of services.
Okay, brilliant. Okay, moving slightly different topics. I'm trying to find the question about PrEP and migrant populations. Who asked it? Oh, it was Ace. Okay, bear with me 1 second. And I can't find him to unmute him. Oh, here we are. Is there any information regarding PrEP access and uptake for immigrant refugee populations in, I think this doesn't just mean Europe, I think it probably means America as well. Dinah, you may have.
Oh yeah, Dinah.
Can I unmute you?
Sorry, can you repeat the question again? Because I was.
Is there any I mean, this is the question. Is there any information regarding PrEP access and uptake for immigrant and refugee populations that you know of?
No, I don't. Well, from our reports, what we saw is that it's not possible for people to get that because they have no insurance that covers that. And also, it should be sometimes, I know that in the Netherlands, for example, it has to be at your home address. And if you don't live in a registered address, it's also not possible. So I think for me, what I've heard from our conversations as well, that it's not accessible for people with a refugee status.
Okay, all right, thank you. I'm getting a couple of questions about the difference between PrEP for men and trans women. I think this is much more a sort of technical hormone level question. Do we know whether PrEP for trans men would be any more or less effective from even the indirect evidence we've got from hormone levels?
Well, for transgender men, the evidence I can very confidently say that to my knowledge, we don't have any data on that. And when we conduct our future to do the IMAC, we think that it should be like among the first study. But looking at the kind of like the pharmacological point of view, the components of the drug, I think that we should expect that there should not be significant interactions to the point that should lower the PrEP level towards the ineffectiveness level. I would say that on the evidence base, I don't think we have it yet.
Any other comments on that?
I mean, what we do know so far is, I mean, there is differences that happen, like, for example, in transmasculine or trans people who were female assigned at birth and who did not undergo gender affirming genital surgery and who take testosterone, that there is changes in vaginal or frontal tissue that may interact or may have an impact on the efficacy of PrEP. So we don't know, like, we cannot just simply take data of cisgender women with vaginas, take that and transfer it to transmasculine people, because the environment down there is just different. As well as the assumption, like there's this stereotypical assumption that that trans people, that all trans people have the genitals that they were born with, and that is not true. I mean, like, some trans people do undergo genital affirming surgery, and we do not know about the efficacy of PrEP in neovaginas or neophallus, and like what potential risk there could be involved in HIV, like with HIV infection. So there is certain differences, and it's also obviously about the sexual practices. Not all trans people with vaginas have receptive vaginal sex. Some people also do have anal sex, or do like penetrative sex with like hands or like toys with other people. Where there's also like intra-trans relationships that we also like not only date cisgender people, we also have we also have sex with trans people. And that is all, like, all these factors need to be taken into consideration when talking about the differences of PrEP efficacy and access to PrEP, or the need for PrEP in between transmasculine and transfeminine trans people.
I want to add something to Matt. I mean, I completely agree with Matt 100%. Also, I want to mention that in regards to kind of the pharmacological aspect, when we did the first study, the IFAC, we didn't think that would have a lot of significant effect on the tenofovir as well, because tenofovir and this is a more transgender when and estradiol and the anti-androgen that we use like protein acetate. Initially, we think that there should not be any significant interaction at all. Even when we found out the results, we still kind of like discuss like how come, or what is the cause of this interaction. We right now we think it should be when hormone was used along with PrEP, but again, this is I think this is why when we mentioned that for the masculinizing hormone, we think that it should not be significant difference, but this is still why we need to do the study to have a very confirming data, so we can use the hormones and PrEP concurrently with confidence.
And I've got to.
I mean, like it's.
Oh, you're gone.
No, I think also, like if there was a study that would actually look into, masculinizing hormones and the interaction with PrEP, that would also send a message to healthcare providers. Oh, there is a need for that. Maybe there's also need for me talking to my patients, to talk to my trans patients about PrEP if there's already a study. It's like, it's kind of like this vicious cycle. There's no data, there's no research being done. So why should we even talk about it? Because maybe there's no need for it, but that is not true. It's just like, transmasculine people and female assigned at birth, or like in general non-binary people, have been constantly ignored in HIV prevention research, and that must stop. You know, this is just like something needs to change in that regard.
I think
yes,
that's
I've
such
got a supplementary. Oh, sorry. Yes.
No, I was going to say, I think that's such an important point, you know, is like that, you know, there's a sense that, you know, there's a sort of that science is objective or, you know, apolitical in some ways, and it's not. And I think, you know, when we're doing these research projects and when we're working with communities, you know, we are thinking about these issues around advocacy. And so like really the need for strategic science, like what is the science that we need? The strategic science that will help us in terms of higher level advocacy work and addressing the structural factors. So I'm really glad we're talking about that.
That's
Thank
a
you, Max.
really good formulation of it. I'm writing this one down. There is a supplementary question from our colleagues in Israel on the same subject, which is like taking it further. I'll try and get the wording right, but it was about actual surgeries. Where are we? I'm trying to find it now. Is there any information about the effective? I mean, I guess I bet the answer is no. Is there any information about the effectiveness of PrEP with different transition surgeries? And are there some that you would not recommend PrEP in combination with? I guess this applies to the surgeries and HIV vulnerability as well. I mean, it's pretty much what the sort of thing you were talking about, Max, but with people who are post-transition or who are considering gender reassignment surgery.
I mean, I think it is safe to say at this point, because of the lack of data, that, for example, event-driven PrEP should not be recommended to trans people on gender-affirming hormones or to trans people who had genital-affirming surgery, because we just don't know whether or not a shield can be built up quickly enough. And what we already know, for example, that event-driven PrEP, that means like taking PrEP not 7 days consecutive before a potential risk event, like to take it up to 2 hours before, like in a double dose, up to 2 hours before a potential risk contact, that this is not enough time to build up a shield in vaginal tissue. We already know that from studies that have been done in cisgender women, but we don't know how it works for trans people. Like we don't know, for example, as I said, with the tissue changes in vaginas of trans people who use testosterone, we don't know, and it's not recommended. Same goes for for trans people who underwent genital affirming surgery. To take event-driven PrEP is not recommended. So generally, like not like to add, probably to go back one step, any person can take PrEP. No matter what surgeries they have done, which surgeries they didn't do, or whatever, any person can take PrEP. But at this point, as I said, we just don't know 100% whether or not if hormones or any type of surgery may have an effect on the efficacy of PrEP. So at least no event-driven PrEP for trans people with these transition-related steps.
Akarin did mention the Bob Grant study on dried blood spots, which I think was very important because dried blood spots indicate a much more sort of longer term drug exposure, and that did not find clinically significant lower levels in either trans men or trans women compared to cis men or cis women. But that's not in tissues, and so tissue is still really important and still under investigated. Okay, listen, I've got a couple of very general questions, and one was a long one from the Ukraine. So, Andriy, if you are listening and you can hear this, would you ask your own question? You have to unmute yourself, I think.
I think it is also okay to say, like, if people want to ask questions in Russian, you can also ask a question in Russian and have the translators translate the question to the panel.
Thank you, Gus. I can speak in English. My name is Andriy. I represent public organization, LGBT organization Alliance Global from Kyiv, Ukraine. I have a question for all speakers about the PrEP adherence of transgender people. Maybe for all speakers. In Ukraine, we have faced very poor involvement of trans people in PrEP obtaining. According to the National Public Health Center of Ukraine, in 2019, only 3 trans people used the PrEP service. A total of 1,804 courses were issued. For example, the problem was that very often the doctors asked transgender community members to refuse from PrEP. Tell me, how do you think it's possible to ensure a better adherence of transgender people to PrEP, and how? Thank you.
Well, there you are. I think that's a good example of what's happening in practice, but how do we find our way through this?
Well, I could start maybe. I think it's very important to have trans people leading the project. That's also what we saw here. If there is anyone in your community program that is trans and can sit on the board and then have specific information adapted so that it is it's better accessing the trans community. That is, I think, one of the things that is really important. If it's LGBT driven, it's mainly not speaking the right language, or it is not the right inclusion. So people really I would really suggest that you take some of the trans people that you know from your community into your program, and then have them develop a specific trans line for information, and as well to have that working together with the other people who are already involved in your program.
Yeah, I mean, I chime in there. I think that the involvement of trans and gender diverse people is essential. And I think the strategies to increase uptake and the strategies to increase adherence may also be slightly different. And so I think, you know, in terms of adherence, I'm part of leading, co-leading a trial with Dr. Tonya Petit, who's now at the University of North Carolina, through the HIV Prevention Trials Network, which is HPTN 091, a protocol, the first protocol that's specifically enrolling transgender women. And we're testing an intervention looking at the effectiveness of co-locating gender affirming hormones with peer health navigation. And so the idea is, you know, in order to increase PrEP uptake, you know, we need to address contextual issues, one of which, for example, is access and monitoring for gender affirming hormones if people would like it. So that's a very important piece. And then the integration of the peer, right? The integration of the peer component to build trust, but not only to really address the real life experiences and issues going on. So that's just an example of sort of really more community-based strategy that's needed. You know, if we apply a broad strategy that we would to a general population, that's one thing. But for trans folks, you know, the specificity of trans experience is going to be essential. You know, so that will be, I think, an essential component of really addressing the epidemic for trans and gender diverse communities.
What we do in Thailand is that we focus on we want to kind of like a holistically approach, going to say like this is a trans specific or any I should call maybe sexual health specific clinic, which not only focus on PrEP but also look at other stuff, kind of like a general health checkup as well. And in addition to that, we also have I'm not sure if I use the correct word, kind of like a dermatology related field to help with the hormones as well. So not focusing on PrEP or HIV testing, but also integrated all these other aspects of general health checkup or health examination in the campaign or the project. And we also use a lot, we also train a lot of key population lead services. So for instance, for MSN staff, we have MSN staff as well. For transgender, we have transgender men staff. For transgender, we have transgender women staff as well. So I think this will definitely help with the uptake of PrEP. And we hope that with all these kind of, I would say like good atmosphere when they come in, but also leading to other optimistic things as well, including the adherence of PrEP.
Guys, we can't hear you.
I did the classic thing and didn't take myself off unmute. I think that's great. I think that actually is the last question on the list in terms of, I think, the topics we've covered. There was another one from Israel, but I think we've just covered essentially that. So it's great. The timing is perfect. We've got 5 minutes. I think we should have a last word from each of the panelists, just to say what you think the sort of wrap-up messages are from the webinar and what we should be working on. Who wants to go first?
Well, I think mine is a little bit focused, so more focused than Sari, and then I can go first. The key message that I really want to convey, and very proud that not only our study, but study from the US as well, help us to be very confident, is that when we encounter issue, when but right now it's only transgender women clients coming in asking us for the counseling of the PrEP, we can now tell them very confidently that you can use PrEP and hormones concurrently without the fear of any diminishing effect, whether it's hormones or PrEP. But for PrEP right now, we know that, okay, yes, there are pharmacological reduction, but when these studies do some, I'll say kind of like the projection analysis, or just the driver spot from Dr. Friend, the latest study, we found that there are a lot of optimistic things. The drug reached the level optimum for prevention. Even our study, all the participants had detectable drug level, which are good sign that the predictive effect of PrEP should still be there. We only need to focus to the same thing, that adherence, have good adherence to PrEP, you can take hormone concurrently. But I want to go a little bit further than that, in that always remember that the hormones is very, very different in different regions. So right now we found that hormone can affect PrEP, even though I mentioned that there are a lot of data say that we can be very optimistic about it. But if some individuals use like very, very high doses of hormone, that could be quite concerning. So I would say that we counseling about PrEP, but also to take hormone with regular monitoring as well.
Okay. Next.
Yes, I could go. I wanted just to again emphasize what Max said. I think it's a very important message that whenever you have trans people who can speak for their concerns and for how their body works and how they have sex as well, that for example, pharmaceutics and the medical staff, so doctors, researchers, can find more ways to include the trans community in all the work they are doing. So I think building that bridge is really key to the long-term success of PrEP in healthcare. So I think this is really one of the outcomes which I really took from the whole panel, and as well from the group that we had gathering all these European countries, that it's really vital to have that kind of information and to bring that back to the table where we can all make better and sustainable healthcare products, and as well for the trans community.
Okay, 2 minutes because Zoom might cut us off. Sorry.
I just gonna say one sentence. Don't, whatever work you're doing, don't do it without us, because like if you're not including us, you won't reach us, and the whatever effort is put into the work is going to be wasted. So please don't do anything without community inclusion.
Okay.
Yeah, I think the nothing about us without us is a very important piece of this. And I think ultimately that is going to be the determinant, the really critical component, I think, that will help us to address the epidemic for trans and gender diverse people. But I want to say that there are gaps still in the epidemiology, thinking about really the non-binary experiences and gender diverse experiences, including, that group, and ensuring what the epi is. Also, thinking about surgical, post-surgical outcomes, and what do we know about that with HIV and PrEP, and the very important pieces. I think the need for the knowledge that like cost is an issue and stigma is an issue, no matter what the context. And that's really what we're seeing, whether it's Europe, whether it's the US, and that's a major piece that we need to address. And then finally, I think the real need for this idea of strategic science that informs advocacy, but also that's translational. So in other words, that we move from the epidemiology to sort of an intervention or programming, and that we move to clinical care, right? We need to kind of have that translational piece. It's the sort of wheel of science. And when I think about that, the community really is at the center. And that is, I'm just want to go back to that again, because we need to be there, and also we need to be in leadership roles, and we need to have community members in leadership roles. Thank you.
Okay, many thanks. Yes, I'm not on mute. Many thanks to all of you. I think that was brilliant. I've got lots of positive feedback coming through on the questions. I want to add one thing. Akarin is mainly a doctor, so he hasn't been sort of specifically involved in this, but I know in Southeast Asia there is some great models of extending the kind of model that they've been using in Thailand into other countries. For instance, there's been a great program of trans-run clinics sparked off in Vietnam, who actually took training from the Tangerine Clinic, the trans clinic in Bangkok. And that's a really good example of how models of trans-centered and trans-friendly healthcare can be adopted in at least one other country. And it's the sort of thing that we should follow. We already have some good resources in some European countries, and we need to be exporting those models as much as we can. Thank you very much. Oh, and I need to give a special thank you to Miroslav and Xenia, our fabulous interpreters. I know it wasn't easy to follow, but many thanks for your very hard work. And I hope everyone could hear it clearly and really enjoyed it. And I'm going to close now, and this will be available as a recording. We will do the research briefing, adding some of the insights from this, and also we will prepare a recommendation document as a result. Thank you very much. And I'm going to close now. Bye.
Bye, everybody. Thank you so much.